So I'm here today to talk about COVID infusion therapy, IV therapy, that is. I have no disclosures today. We'll start off by talking about the operational components needed for a COVID infusion therapy clinic. The first one on here is what I've been doing for the last 2+ years is the APP point person. While certainly not the most important person in this whole operation, it's nice to have someone that everybody can connect to, whether that be, pharmacy, patients, billing, providers that have questions about referrals or what's the current state of things with COVID therapy. It's very important to have that one centralized person. You need support from APP leadership. We never had someone that solely did COVID therapy. So this was all kind of supplemental time for everyone that wanted to pitch in. And the APP leadership helped with credentialing and staff support to find folks that could help out. You really need a robust referral system because without being able to get patients to our team to call to screen, there really wouldn't be folks to call to get this therapy. So we worked really closely with our IT department to get this referral system set up. And there was actually a time when we had to back down when Delta hit, the Delta surge. There was over 1,500 patients at one point in our basket. And so we had to change our referral at that time to be able to kind of triage these folks. And how we did that is we put in the referral, is the patient immunocompromised? Are they pregnant? And also the symptom onset date, so we could sort these patients and triage them to call the highest risk ones at those times. You need pharmacy support. This was very important in, getting the actual medication, getting the drug to the clinic, because in the early days, our clinic was off-site. We didn't have a pharmacy there. So we had to get these mixed up at the hospital, and then a courier would bring them out and we would store them there. But they were helpful in letting us know how long was the drug good for, how long was it stable in the compound, and also any questions that came up. So we always have a close contact with pharmacy that helps us with that. And they were also the ones that would let the state know what our supply was, and then they would let us know how many we were getting for the next week. So that would let us be fluid in saying, can we bring everybody in that's high risk, or do we need to start triaging folks to say which ones are the highest risks that we can treat this week, the ones we're going to do the most benefit for. So pharmacy has been very helpful throughout this whole process. Nursing, front desk staff. You need a good nursing staff that is comfortable with infusions and also comfortable evaluating patients that could have severe symptoms. They would, along with the provider, assess patients and also do the teaching before they'd go home is what to look out for afterwards. You need a strong medical doctor partner. I was lucky enough to have world-renowned infectious disease specialist, Dr. Cameron Wolf, who I would not be able to do this without. This allows you, or will allow me at least, to call him whenever I had complex patients, because so many of these patients are not straightforward, especially now. A lot of gray area, getting through the weeds of what's really going on with the patient and discuss what's their, immunocompromised status, what's their risk of developing severe COVID, and talking through what's going on with the patient at that time and formulate a plan really of what we're going to do for them. Electronic health record support. Again, the building of referrals, getting the medication orders in, because these would change. A lot of them were under the U.S. emergency use authorization, and the medication changing frequently, how fast the infusion could go in. All that's built into the medication order set. So definitely needed support there. And then billing on the back end, how we were putting our notes in, how are we billing for these patients to get any reimbursement we could for the work that we were doing. You need an infusion clinic site. Sounds simple enough, but in these times, clinic space is a real commodity here at Duke. And to have a dedicated site was important. And we were able to provide that and have it for a long time. You need a home health team. This really allowed us to get the patients that could not get to the clinic, whether they would have transportation issues, didn't feel comfortable enough to drive themselves, or have a family member or household member that could bring them there. And also, when you think about home patients that are on a home vent, the kind of the operational aspects of getting them to a clinic was tough. So we often lean on our home health team that gives these infusions at home. They can go out, the nurse goes out and essentially evaluates the patient, and we put the orders in and everything, and then keep in close contact with them afterwards, make sure that everything was done. So what's our workflow? The workflow we use from start to finish, when a patient gets COVID till we actually get them an infusion. So patient gets COVID, whether it be a home test or they have symptoms and go into one of our clinics and get a test done at one of our facilities. After that, a referral is placed by the provider. That can be from their own PCP, a specialty service, or the emergency department. And actually, employee health has their own referral system set up where they can send us patients that they think are high risk and need some COVID support. We also have a number set up that patients can call and refer themselves if they believe they are high risk or just want somebody to screen them for COVID therapy. After we get the referral, the covering APP calls the patient and screens them for appropriate therapy. And if we see that they meet criteria for an infusion, the APP will actually order all the medications at that time, self-schedule the patient. It saves the patient a phone call. We found this very helpful when we rolled out vaccinations, and it was the same number that patients were calling to get set up for vaccinations and to get scheduled for infusion therapy. So I got all the APPs the ability to just schedule themselves. We found it, we had a lot better rate of patients actually going because we would save them a phone call and get them scheduled right then and there. And then we give them the information, the address to the clinic, the number they call to check in when they get there. Again, because we don't want them just going into the clinics. We want them to have clear directions. So if they wait in their car, they call, get them checked in, they come into the clinic, and they're screened by the nursing staff and the advanced practice provider to make sure that they're not too severe. If they do need attention in the hospital, we will activate 911 and get emergency services there to get them to our ED for higher level of care than just giving them an infusion. So IV COVID therapy, kind of a quick history of how we got to where we're at now. Previously, we were just giving monoclonal antibodies when they were available. This was a one-time infusion. Patient would come in for one visit and get these antibodies and then go home. Now, we're currently giving IV remdesivir, which, unlike an antibody, is an IV antiviral. This is a 3 infusion course. We'd like to get those done on consecutive days if we can. And this consists of a 200 milligram loading dose followed by 100 milligram dose on days 2 and 3. And we've really had to we've been back and forth with these, at least at Duke, because we really need to be fluid with changes in the variants and supply. We talk about variants. One monoclonal might work for a while, but then as new variants come out, it may not be effective. And when there was a time where supply was running low, or we didn't have another antibody yet that would work with the variant, we would switch over to remdesivir. And with that, we would change the clinic schedule. We would be open 7 days a week to try to get these in those 3 consecutive days. And then we were able to go back to monoclonals when either we got supply or there was one that was approved for the variant that was out. And I work with Dr. Wolf with this, and we would look at the numbers at Duke of, what was the most common variant? What was the variant that, once we hit a certain mark of 40% was of the cases were the new variant, that's when we would usually switch over. Or if that was ineffective, we would switch over to the IV remdesivir. But right now, there are currently no antibodies that are approved for COVID at this time. So that's why we're just given the remdesivir. Who are we prioritizing for this IV therapy at this time? Right now, we look at our pulmonary patients. This could be cystic fibrosis patients. The big one is lung transplants, interstitial lung disease. These are patients we really worry about because they're the ones that get the more moderate to severe symptoms, the respiratory stuff that really can put patients at danger. Our bone marrow transplant patients, our MGUS patients, and our CLL patients. These 3 here, really, when you look at them, they're all immunocompromised. And those are the folks we worry about, because even if they are vaccinated, you never know what their response to the vaccine was. Was it a robust response, like a healthy individual, or did they not really build any immunity for that, for COVID? So that's why those patients kind of get to the top of our list when we think about who's going to benefit from these. And these are we look at these patients, at the bottom here, we have, other complicated patients. And these folks, firstly, it would be patients that cannot take Paxlovid, because we view Paxlovid as being just as effective as remdesivir if being able to take it home. And there's, a lot less operational, firewalls around being able to take a pill at home rather than bringing someone to a clinic 3 days in a row. We also look at patients that have high BMIs and maybe unvaccinated. We know those patients don't do so well a lot of times. So these are done by a case-by-case scenario, and I do talk to Dr. Wolf about these, and we formulate a plan essentially together. So it's very nice to have that in place, so we really can look at the individual patient and see what's going on with them. Current state. Where are we at now? At Duke, I think globally right now, numbers are down. Not as much COVID going around, and certainly not as much severe COVID. Our hospitalization rate is down. We don't have these COVID patients taking up a lot of hospital space like previously. But at Duke, we do a lot of transplant, and our patients are spread out across the state and other states here in the US. So we really want to prioritize oral antivirals when possible. If patients can take Paxlovid, we do that, because our staffing model right now, we can only start these IV remdesivir infusions on Monday, Tuesday, or Wednesday. That way they can get the 3-day consecutive course in before the weekend when we're not open. So what do we do when patients, are high risk and we're concerned about them, but it's a, Tuesday a Thursday or a Friday? Well, a lot of times if they can't take Paxlovid, we'll bridge them with molnupiravir. And so we're at least getting some antiviral started with them, because we know the earlier you get anything started, the better. So we'll bridge them until Monday, when we can get them into the clinic for an IV remdesivir dose. If we're really concerned or the patient deteriorates, then we'll reach out to our partners in the emergency department and try to get them set up with an in-house dose of remdesivir to get them started. And then we get another set of eyes on them and get vital signs, see how the patient's doing, and see, if they need to be admitted or can they be discharged home, and then we can finish up the course starting on Monday. We also have the option to reach out to our home health provider team, and they can help get set up infusions for these patients either in home or at the nursing home they're being cared for. So because our census has been so low, actually last week we just consolidated our clinic into the hospital-based infusion clinic, where they give iron infusions, some blood transfusions, among other things. So we had to go about this very systematically and say, how do we do this and not put other patients at risk? So what we do is we schedule these at 5:00 p.m. and then all the other patients are out, and we can bring in the COVID folks to get an infusion. So this has certainly helped with staffing. I think everybody's short-staffed right now. So we're not staffing 2 clinics, especially, like I said, with our census being so low. And these providers and nurses they're very experienced with giving infusions. So it's been helpful to kind of consolidate this and still be able to provide this service for patients that are at high risk for going in to the hospital. And that'll wrap my time up. I'm happy to answer any questions that anybody would have and look forward to the discussion afterwards. Thank you.